Hello, everyone. This is me and Maggie's case presentation.
All right, for this case presentation, we are going to be presenting about an acoustic neuroma. In this case was done by Nascentes et al. In 2007, and it was published in the Brazilian Journal of Otorhinolaryngology. And so why did we choose this specific study? We chose it for a whole number of reasons. Importantly, this is a unique case of sudden sensorineural hearing loss. And this case really takes you through the process of diagnosing and treating sudden hearing loss, and then figuring out what the causes could be. In this case, it was an acoustic neuroma. And the way they found this was through the imaging that they did. So the importance of imaging in the diagnosis and assessment in this study was really important to us, as well as the interprofessional collaboration that occurred throughout the study. So all the different team members that were part of the patient care, diagnosis, assessment, and ongoing monitoring. So all of this together was why we decided to go ahead and use this study. So the case history for this patient, we have a 38-year-old male, Caucasian from Brazil, specifically Bauru. He's married and works as a repair shop manager. In January of 2004, he came to the ear, nose, and throat doctor, the ENT, presenting with a sudden left sensorineural hearing loss. Well, they didn't know sensorineural yet, but a left ear hearing loss and continuous high-pitched tinnitus in his left ear. He denied vertigo, neurological alterations, previous pathologies such as upper respiratory infections, otitis media, diabetes, high blood pressure, things of that nature. And he also denied use of medications.
So the first step for this individual was getting a physical examination done. The results of this examination were found to be within normal findings. So they did otoscopy and they found an intact bilateral tympanic membranes. They did find a mild nasal septum deviation to the right side. However, the tonsils were identified as grade 1, which means that they were normal size. And there was an absence of palpable lymph nodes. Here is the first audiogram that was taken for this individual. As you can see, the right ear is within normal limits. It's pretty flat as well. And in the left ear, you can see a more severe finding after that 3000 hertz range. And it has been identified at this point as sensorineural hearing loss. Just other findings from the audiogram includes a WRS score of 92% and an SRT of 15 dB within that left ear. So what was found was that they decided and suspected sudden hearing loss. From this suspicion, they ordered blood work and started prednisone along with pentoxifillin. And prednisone, as we know, is a steroid that is typically used for sudden hearing loss. And pentoxifillin is part of the hemorrhagic agents that typically is used to improve blood flow within patients with circulation issues. Presumably, these prescriptions were taken orally. However, it is not specified within the report. One week later, this individual returns and reports partial improvement in both his hearing and tinnitus within that left ear. The blood work also comes back and shows complete blood count to be normal. It shows that the fasting blood glucose, which is just the amount of sugar in your blood to test for diabetes or pre-diabetes, this was found at 103 milligrams per deciliter, which according to the CDC is within the pre-diabetes section, which establishes 100 to 125. Then the cholesterol was found at 175 milligrams per deciliter, which was considered to be normal considering it was below 200. The triglyceroids, this is a type of fat that is typically found in the body, and it comes from foods like butter, oils, and other fats that you eat day to day. His was found at 481 milligrams per deciliter, and this is typically to be within the high range. The high range is from 200 to 499. And at these high levels of triglycerides, you are more at risk for heart disease. Then the VDRL was also done. This is the Venereal Disease Research Laboratory. This detects any antibodies that present in the bloodstream and is looking for syphilis. So the fact that he has a negative result on this means that there was a non-reactive identification that is compatible with a person who does not have syphilis.
So after these test results, these lab results came back, they did another audiogram. They found that the right ear is still within normal limits, and they found that the left ear recovered from severe hearing loss. They labeled that as being a light sensory neural hearing loss after 3,000 hertz in the left ear, but we classified this as a mild sensory neural hearing loss from 4,000 to 8,000 hertz in the left ear. You'll see as we go on, some of their results are described in a way that we don't necessarily concur with. So we give our own thoughts as to our interpretation of these results. Light is just not a category we use, so we decided to classify it our way. So based on this audiogram and the fact that the hearing loss recovered just a bit, along with the lab results, what are they going to do now? They decided to suggest a better diet or a different diet and a new medication. So they prescribed Ginkgo Biloba, which is an alternative herbal drug therapy used to improve blood flow, because components of this herb are believed to have flavonoids with antioxidant qualities, as well as terpenoids that help improve circulation. And so this is something they prescribed, as well as ordering an MRI and a BERA, which is very similar to an ABR and is something we will go on to discuss later in the presentation. So they ordered both of those, but they didn't give us the results of those specific tests. They do give us an MRI that happened later, but these specific tests that they ordered at this point in time, they didn't give us access to that information. So we don't know what happened exactly at that point when he came back that 1 week later, but we have results from 5 months afterwards.
So 5 months later, this individual returns with reports of worsened hearing and tinnitus in his left ear. He stated that this was within 4 days of evolution, meaning that it just occurred 4 days ago and has resulted in this noticeably worsened hearing loss. However, he did deny vertigo. Here was the audiogram that was established. From the report, they said that the right ear was within normal limits, which hasn't changed since the initial audiogram. And then they established that the left ear was severe high frequency sensory neural hearing loss. Based off of our own interpretations, like Maggie has said previously, we identified that this audiogram was more within the mild sensory neural hearing loss range from 4,000 to 8,000 hertz, which is a little different than their severe category. Just another note on this audiogram, the SRT has elevated just by 5 dB within the left ear from 15 to 20. So what now? Now they decided to prescribe additional medication and have another MRI. They prescribed the prednisone again, along with the pentoxifillin, which they used at the initial treatment. However, it should be noted that after the patient was prescribed these, he reported little improvement.
So the results of the MRI come back and they demonstrate that there is in fact a lesion. They found an expansive solid mass measuring 5 millimeters in diameter, and it's inside the internal acoustic meatus. Now, the images that they gave us don't exactly label the left from the right, but in my experience, on the left side, our left side of the image is the right side of the person, and then on the right side is the left side. So if we're looking on the left side, we will see that something looks a bit out of place on this left side in the region of the internal acoustic meatus, and it is right here. So from what we were able to see, this is what it looks like the lesion. This looks like the location of that lesion, and it's likely the acoustic neuroma is this white spot right here. And so it gives you a couple different views of that there. And so just a breakdown of the internal auditory meatus or acoustic meatus. It's a canal in the temporal bone extending from the cochlea medially to an opening in the posterior aspect of the petrous portion of the temporal bone. So it's just giving you a nice illustration of where that neuroma was sitting. And it's right up against the auditory meatus and right near that cochlea, the hearing organ. So that would be what's contributing to the hearing loss that we see presenting in the patient. This is just another example, a more physical representation of where the IAM is. And so we have the explanation of this skull here. We have the man pointing, well, a person pointing to the opening in the skull where the internal auditory meatus would be sitting, and an image of the brain and how it actually connects within a person's flesh. And this is just a demonstration to compare to the MRI imaging that demonstrated where that lesion was. And so after all this, after looking at the imaging, the radiologist figured out that there was a lesion there. So they referred to a neurosurgeon, and the neurosurgeon decided to observe the person clinically rather than pursue further treatment or surgical procedures.
So let's just discuss the vestibular schwannoma, which ended up being the resulting cause of all of these symptoms for this individual. So we thought it was important to note that the most frequent tumor type found within any acoustic neuromas, well, the most frequent tumor type is typically at the pontine angle, which is located between the pons and the cerebellum. This corresponds with approximately 9% of all intracranial tumors. And you may be asking yourself, how does this relate to the anterior auditory meatus? So the folliculus of the cerebellum, which is just kind of the exterior portion of the brain, may lie within the cerebellopontine angle and may be closely associated with cranial nerves 8 and 7 as they cross over this angle into the entrance of the anterior auditory canal. So just based off of all of this, both of these components are really close together and can impact each other. So we thought it was important to bring up. The next bullet point here is that the hearing loss is typically unilateral and progressive in these types of patients. This impacts the hearing discrimination more than the auditory acuity, and is found within 20% of all cases of acoustic nerve tumors. It is also important to note that if this tumor is big enough, it may also impact the facial and trigeminal nerves, along with even having any presentation of central neurological manifestations. Then we get to the next bullet point with the sudden hearing loss. So the sudden hearing loss can occur because of the occlusion of the labyrinthine artery. This occlusion is just saying that the tumor is pressing on that artery, which creates the hearing loss, which is the typical cause of it. This occlusion may be due to the outside compression. It may be due to a thrombosis, which is the intravascular involvement, or it may have involvement of wall thickening with the vessels, or a neuroendocrine factor, which is also known as a vasoconstriction. Then just to say a little bit about the treatment that was decided for this case, they used the prednisone and pentoxifillin, which were the first two medications and the last two medications. As we know, these two have been known before to be treated for the sudden hearing loss, and it is clinically significant until the etiology of the diagnosis is established. And this is really when you get into the importance of the imaging and how the imaging really helped establish this diagnosis. Just a little short thing about the Ginkgo Biloba medication. This has also been known to treat sudden sensorineural hearing losses, and in other studies, it has been shown to improve hearing recovery. So just to talk a little bit about the importance of the imaging that was done and the BERA. So both of these things really assisted in identifying the etiology. The MRI is the most significant and sensitive method of detection for this type of tumor, and it really helped establish diagnosis. It's a non-invasive tool that really looks at the soft tissue in the brain and helps identify where the lesion is. So it helped identify where this vestibular schwannoma was. It is also really important for any follow-up visits, for it can be used to monitor the growth or stability of this tumor, which is important for this individual based off of the neurosurgeon's recommendation to clinically watch him. And if surgery was decided along the road to be taken, then it can be used as a monitoring tool to do pre-op versus post-op and see the difference there. The BERA, or the brainstem evoked response audiometry, is also considered to be the ABR. This is less sensitive when considering the MRI when detecting this small vestibular schwannoma. It has a false negative rate of about 33%. However, it is less expensive, so it is a really crucial tool. It also helps verify any of the behavioral thresholds and can recognize the lesion if the signal is not getting up into the brainstem. The result of any of those tumor blockages may look different depending on size and placement. So this can alter the thresholds and possibly alter the waves and the latencies of those. And finally, just talking a little bit about the interprofessional practices, the IPP. The first person that this individual went to was the otorhinolaryngologist, or the ENT. This was really where everything got established. Then the audiologist helped with all of the audiograms. As you can see, this person got free. Then we have the radiology technician who took the imaging, the radiologist who identified and read the imaging and saw the vestibular schwannoma. Then we have the pharmacist who prescribed all of the medications. And the neurosurgeon was the last person this person was referred to, where they decided to do the clinical watchful waiting. So as you can see, all of these people work together to really help this individual.
All right, and that's it for this case study presentation. If you have any questions, we look forward to answering you on the discussion board. And I will show our references. All right, see you on the discussion board.